I have the impression that these patients are highly satisfied with their outcome and that they're highly satisfied pretty quickly in the process. I've seen only a couple of failures. Most of them have been very successful so far. And we are looking into the application of this type of technique for more degenerative lesions, such as early OA patients. So this is a left knee medial condylar lesion. We'll mark first the patella and the tibial tuberosity, and so the tendon. Okay, so next we have a lesion. We'll mark the lesion in this area in the extension phase. The lesion is here. This is bad cartilage. The next one is sizing. This is the instrument. We place the sizer across the lesion. But remember, this is three-dimensional surgery, so we need to know that it's full contact. Also inclination to the left medial side or to the lateral side. Anterior and posterior needs to be full contact, because this will determine the pin. We introduce the pin into the sizer. Okay, so we have the sizer, we have the lesion. Full contact in all three dimensions. And then we introduce forward drilling, a pin with a laser mark. And we go there you are. So a laser mark is in line with the sizer. Try to not do this at full speed to have full control, and also to reduce thermic effect of the pin drilling. We take off the machine. We take off the sizer, and so the pin should be perfectly centered. Very important, this is your basic step. Once this is done, surgery is actually done. If this is wrongly positioned, please take it out, correct it, and put it back in. So the drill sleeve not only serves to protect you against the soft tissues, but also serves as a depth stop. So this is in full contact with the surrounding cartilage. And then this will drill you to the exact depth. Okay. Full contact, 12 millimeters under the surface of the surrounding cartilage. The implant itself is 10 millimeters. So we are at the level of the subchondral bone at the final stages. At this point, the lesion should be gone, and only healthy, intact cartilage should be at the edges. The reamer also has a very well indicated laser mark, which will now ream the bottom of the defect. Also, remind yourself that there's always a tendency to drop the instrument because of gravity, so keep well aligned, and you see that the laser mark is nicely surrounding the cartilage at all levels, in all dimensions. So we gently ream the bottom of the defect. We remove the reamer And between every step of preparation, we always flush. So at this point we flush, and now we move forward to the next step. Progressively, gently, and under full control of the direction, so the lesion is nicely fitted. Yeah, yeah. At this point the final shape is made of the defect, and so wobbling should be avoided. We repeat this step. In between each step we flush to take out all the debris. So at this point we take out the central pin. This instrument is called the cartilage cutter. It has a specific blade here on the side, which should be aligned with the edge of the defect. And you can actually nicely follow the bony edge, and it will cut all remaining loose ends of the cartilage. The trick is to avoid any free cartilage entering upon the impaction of the implant with the implant, and thus hindering ingrowth from the periphery. So we go in and we nicely position the implant just in front, and then it should slide in gently. This is the most important step. Okay, and with gentle finger pressure, no instruments, fully aligned with the defect. And now push it at the level of the cartilage. It's now fully leveled. Temp again well aligned, full coverage, and gentle. The implant should be well aligned with the subcondylar bone.